And now we have Dr. Sudhank Bharti, one of the renowned eye surgeon from Delhi, and he's one of the eye surgeons who started the refractive surgery very early, the earliest starter. Dr. Bharti is going to speak on post-RK cataract surgery management pulse. Dr. Bharti, please.
Thank you, Dr. Vinod, and thank you, Dr. Rajendra Prasad, for giving me this opportunity to be part of your instruction course today morning. And I am so delighted to see so many attendees, so many delegates coming so early in the morning to attend the sessions. I'll be talking on the cataract surgery after refractive surgery. I've been doing radial keratotomy since 1985-86 and did quite a number of cases before I started doing LASIK in 1995. So the topic is very exhaustive, and there are so many things which one has to discuss, but I'll be limiting myself to one of my videos here, which is radial keratotomy done almost 20 years back, and now a case of FLACS, the femtolaser assisted cataract surgery. You can see that the incision is opened. There is a stigmatism in this particular case. So I am going to put a toric techness IOL, because the techness is the best, as already discussed earlier in the question answer. And you can see that there is a very nice capsulotomy done by the laser, and the incisions, the cuts which are there because of the laser, they do not hamper the effect of the femtolaser in reaching the lens. So there is no defect in the capsulotomy, and there is no need to pull the capsulotomy out. It is already separated, as you can see. And then simple phacoemulsification. I do not normally do capsulotomy or capsular fragmentation with the femtolaser, because I find that is sometimes goes deeper than what you expect, and that's not a very good idea. So I chop the lens myself. There are marks, and you can see that I have gone between the cuts for my major incisions, which is the advantage whether you're doing manually or with the femtolaser. And once I have divided into multiple fragments the nucleus, I'll remove these fragments one by one very quickly. They can be emulsified, because in this particular case it is probably a grade 2+3 or 3+ cataract. And then removal of the epinucleus is not very difficult. The only thing which I wanted you to notice was that I rotated the nucleus so that there was no corticocapsular adhesions. These are removed very peacefully with the rotation of the nucleus, so that the corticocapsular adhesions are, and it's very easy to remove all this cortex and polish the posterior capsule, which is very, very important, because if you are left with some cells, then you will have the posterior capsular opacification, which when you do a YAG, there is a possibility of CME after that. And then you inject the IOL, and IOL I would not prefer to inject completely inside. I want to gradually insert it within the capsular bag and gently rotate it. And as you can see, despite the fact there is so much of manipulation, the lens being manipulated, there is no problem in these cuts which are there on the cornea. There is no problem of opening them. I never did myself anything more than 8 incision radial keratotomy in my life, which was almost 10 years. I might have done about 150,000 radial keratotomies. But these incisions are pretty strong once you have kind of taken almost 10 years or so. After that, there is no problem. These incisions do not give way. The only thing is, once you have manipulated so much, there will be some disturbance in the incisions, and these incisions will gradually heal once again and go to a little bit of hyperopic shift. So you have to take care of that while you are doing the cataract surgery. and then you hydrate the you ascertain that the lens is situated or placed at the angle which you wanted. As you can appreciate here, the axis is correct, and once this is achieved, the procedure is over. Now the most difficult thing is IOL power calculation in all these cases, and this is what I thought that I'll talk about, because the rest of the thing is management of the lens and other things about the the phacoemulsification or femtolaser assisted cataract surgery. It's all very simple, but the IOL power calculation is basically a very difficult subject, and still one gets a hyperopic kind of IOL power after the thing, or sometimes there is a residual myopia. So there is still, you cannot pinpoint as to what is the problem in calculating, and majority of times it is because of the K reading which is not correct. So there are different relationships between LASIK, PRK and RK, and there is altered ratio between the anterior and posterior corneal curvature, which is the culprit for bad calculation. And there are so many formulas, the Barrett and the formula used in the corneal power in two ways. The corneal power is directly used in the Vergennes calculation, or corneal power is also used in the prediction of the lens position, effective lens position, as to what kind of distance between the cornea and posterior capsule you are looking at. This is very important, because whenever the corneal power is different, the flatter, it says the AC depth is also less and the lens is sitting forward. So these things are very important. There is an underestimation or overestimation of the effective lens position, which is very important. Radial keratotomy flattens both the anterior and posterior corneal surfaces, though there is not much of a difference in the anterior posterior corneal curvature relationship, but the problem is the small optical zone, which is what we have to measure. And in the RK, the posterior corneal surface undergoes a more evident flattening, and this causes overestimation of the corneal power, and IOL power is becoming on the hyperopic side. In the LASIK or PRK or SMILE or LASIK, whatever laser correction we are doing, the anterior corneal curvature is changed, and it does not change the posterior corneal curvature, thereby altering the normal anterior posterior curvature ratio, which is again very important, and one has to assess as to what kind of corneal curvature we are looking at, ultimately anterior and posterior both together. But the optical zone is much wider, so there is not much of an issue, because of the calculation of the corneal curvature is not very difficult. So other thing is as I said, effective lens position, and this is actually the matter when you are calculating because of the curvature of the cornea, the effective lens position is erroneous in calculation, and this causes underestimation of the IOL power, and special methods are to be used. So there are many methods like clinical history, over refraction, topography based post LASIK adjustment, central ring topography and net corneal power measurement, and post laser correction. Most of the methods are accurate, give you reasonably accurate result, but post radial keratotomy, these things are not so well understood and not So topography based post LASIK adjusted keratometry is not suitable for RK eyes, but you can do that with the formula which are present in the website, especially with the ASCRS formulas. And central ring topography, which is very, very important. What I follow is the Aramberry method, which is mentioned here. And one should go back and read the Aramberry system of calculating the radial corneal power after the refractive surgery, which gives mostly very, very accurate results, and these are very important. What I use is Pentacam. It is a method which gives you a very accurate calculation of the anterior and posterior corneal curvature, and then it gives you a very accurate corneal power. So post-refractive surgery eyes, the double K formula or a true K formula, these two formulas are absolutely, gives you bang on keratometry powers, and there you can, kind of think of using them to get the corneal power correctly, and then use them as a true corneal power. So that is the best way to go forward. So double K formula is, it's a very difficult thing to explain in 2 sentences, but at least go back and read Arambari double K formula. This is a wonderful method. I'll just finish in 1 minute. So that is all. It is now considered, the Barrett True K is considered one of the most reliable options for myopic and hyperopic PRK or LASIK, laser visual correction. So personal choice is on Pentacam, 3 mm zone, both vertical and horizontal axis, and antecorneal curvature plus posterior corneal curvature divided by 2, as I use as K. Thank you very much.
Thank you very much for Dr. Bharti for with a beautiful insight of how to tackle the post-RK cases for cataract surgery. Thank